it to say that balloon procedures for aortic stenosis often work in children but are never curative, nor is surgical valvotomy. Bicuspid aortic stenosis recurs after valvuloplasty. And not all that is aortic stenosis is bicuspid or tricuspid. There are unicuspid or even quadricuspid valves, and it behoves us to understand that anatomy because an interventionist can't intervene on a unicuspid valve. You'll just tear it and create bad AR, whereas a bicuspid valve is often amenable to intervention, and certain kinds of bicuspid valve are more associated with ascending aortic dilatation than others. So the very specific morphology of the aortic valve, it's insufficient to say it's bicuspid. You have to know whether it's left-right fusion or left non-fusion to understand the complications that will go with it and the suitability for percutaneous procedures. And not all that is left ventricular outflow tract obstruction is aortic valve stenosis. Unfortunately, a common error we see is attributing subaortic stenosis, either with a membrane or a muscle bar, to aortic valve disease and wondering why a balloon doesn't work. So there's both subaortic stenosis and a little more rarely, but in association with an autosomal dominant syndrome called Williams syndrome, supraaortic stenosis, which obviously needs a surgical approach. We've spoken about coarctation, but just to list what the late problems are, probably the most dreaded of all are the aneurysms of the descending aorta because they're clinically silent until they cause a big problem. But as I mentioned, about 40% of successfully repaired, wide open coarctation channel children and young adults get hypertension that requires treatment, and that goes with a propensity to coronary artery disease and cerebrovascular accident. So surveillance for those are really important. And the hypertension is sometimes not apparent on rest. It's very important to exercise people who have had coarctation repair because sometimes their resting pressure is 130 on 70, but after stage 1 of a Bruce protocol, it's 200 on 70. They have very twitchy vessels which require treatment to protect them from exercise-related complications. And this is the bad complication, the one we hate, the one we do surveillance for, the large descending aneurysm, usually after patch repairs of aortic coarctation, and you can see there the proximity to the left main bronchus. Recoarctation, there's a big debate about the treatment of native coarctation, but there's no doubt that recoarctation is easy and very satisfactory to stent, usually with a covered stent because of the rare chance of dissection in the region of a recoarctation. And you can see in the top two slides the before and after appearances of a successful stenting for recoarctation. A few words about Tetralogy of Fallot. Everyone knows what the 4 parts of the tetralogy are: the right ventricular outflow tract obstruction and the consequent RV hypertrophy, the ventricular septal defect and the so-called aortic override. But it's no accident that those 4 always go together. I mean, why isn't there a trilogy of Bailey or a duology of Cordina? It's a Tetralogy of Fallot because it's all the one embryological defect. And that embryological defect is cranial displacement of the infundibular septum. What does that mean? That means that when the infundibular septum grows down to meet the muscular septum coming up, instead of hitting it right on, it dives forward. It's displaced a little bit towards the sternum. And you can see on this slide the consequences of that. Here's the infundibular septum, which should have grown down onto the muscular septum, but it hasn't. It's been displaced towards the right ventricular outflow tract, creating the 4 parts of Tetralogy of Fallot: the subpulmonary stenosis, the RVH, the VSD, and the aortic override. So it's a single lesion with 4 consequences. And Yishe will talk much more about the corrective procedures, so I will skip over those. Just to show you what a Blalock-Taussig shunt is, thought of by Helen Taussig and executed by Alfred Blalock in the mid-1940s. And there are other kinds of shunt because when you're born with tetralogy, you don't have enough pulmonary blood flow. The infundibular stenosis means not enough blood is getting out the lungs, and so the idea of these palliative procedures is to enhance pulmonary flow. The price you pay is you overload the left ventricle. It's like a ductus. You have a high left ventricular volume load, but it allows the baby to grow safely until the age of complete repair, or at least it did before the surgeons worked out how to do complete repair very early on in life. And a Glenn operation was a very clever way of augmenting pulmonary blood flow without causing a volume load from the left ventricle, simply by anastomosing the SVC to the pulmonary artery. So if you hear of a Glenn procedure, The cousin of the famous astronaut did this first. That's what it is. It's a venous shunt into the pulmonary circulation. This is what we hate to see after tetralogy of Fallot repair, because very wide QRS usually identifies a big scar on the ventricle and or a big right ventricle and a risk of sudden cardiac death. That's what transposition is. The aorta arises from the RV and the PA from the LV, commonly associated with ventricular septal defect or pulmonary stenosis. And there are two ways of repairing it. Until about 1990, the common way was to switch the inflows, the so-called atrial switch operation. But since about 1990, the procedure of choice is the arterial switch, where but Yishay will go into that in some detail. But suffice it to say that there are still lots and lots of young and older adults in New South Wales, Australia and beyond who have had the atrial switch procedure and to run into terrible problems with arrhythmia or heart failure because their subaortic ventricle is a right ventricle and God didn't design it for that purpose. So 40% are remarkably well, but the atrial baffle repair kids and young adults get into problems of the nature listed on this slide. Now, the thing we obviously, the most dreaded complication is sudden death in CHD, and just to say one thing about that, it's often an arrhythmia that in you or me would be benign, but because of a hemodynamic abnormality like a pressure overload or a volume overload or cyanosis or a single ventricle, atrial flutter can be lethal if you've only got one ventricle or if that ventricle is a subaortic RV. So please remember that atrial arrhythmias in the setting of congenital heart disease are absolute emergencies as opposed to the situation in acquired heart disease. Just one or two final slides about other terms you may hear. Congenitally corrected transposition of the great arteries is where the blue blood ends up in the lungs and the pink blood ends up in the aorta, but they go via the incorrect AV valve and the incorrect ventricle. So blue blood goes through a mitral valve into a left ventricle and out the PA, comes back to the left atrium like it should, but then through a tricuspid valve, through a morphological right ventricle to the aorta. And the reason that's dangerous is it goes with a lot of other things like VSD, pulmonary stenosis and heart block, as well as the right ventricle being a subaortic right ventricle, as well as often Ebstein's anomaly of the tricuspid valve. So this is a complicated lesion, and I think if you ever see a CCTGA, probably worth referring on because it's a tricky lesion to treat. And we already spoke about tricuspid atresia, and just to introduce the concept of how you repair that or how a surgeon repairs that with a cavopulmonary connection, getting rid of the subpulmonary ventricle and allowing the lungs just to fill by passive flow, and during inspiration blood is sucked into the lungs. And again, Yishay will go into detail about the types of total cavopulmonary connections that have been performed and the consequences of that for our patients. That's an angiogram of an SVC and an IVC into a PA, which is a lovely result and compatible with a relatively long and relatively happy life. The Cardiac Society of Australia and New Zealand have recognised the special needs of young adults with congenital heart disease, and so many people around Australia got together to recommend standards of care, and I commend that document to you as a good starting point about transition from paediatric to adult care and how to build a regional or comprehensive adult congenital heart disease centre. So to finish up this very early introduction, the adult CHD population is growing in number and complexity, particularly so in sites where there was very active congenital heart surgery from the late 1960s, such as the Children's Hospital in Sydney and Royal Melbourne Children's Hospital, but there are now very large adult congenital heart populations in every state and territory of Australia, both islands of New Zealand, and of course in the Asia-Pacific zone in general. But the most important thing of all, the reason we're all here today, is that cure is rare. Really the only thing that is curative is a ligation of a persistent duct early in life. Even an atrial septal defect, scar on the atrium, atrial arrhythmias, now very good follow-up papers showing abnormal life expectancy, even for people with ASD repaired early in life. So if you see someone with a scar on the chest and they had an operation when they were a child, we all have to take it very seriously. So that is the end of my introduction. Thank you very much.